Hi students, welcome back. We are now moving on to the fourth segment of Chapter 10. In this segment we're going to be spending a little bit of time talking about opiates, stimulants, and hallucinogens. Some of the harder illicit drugs that people can become addicted to and develop a use disorder. Slide 28. I'm going to start off talking about opiates. Opiates are a group of addictive sedatives that in moderate doses relieve pain and induce sleep. Things like opium, morphine, heroin, and codeine. There are synthetic sedatives, which are a separate category. They're considered hypnotics or anxiolytics, and generally those are prescribed for sleep disorders or they are prescribed for anxiety disorders. It doesn't mean that they can't be abused, but they are considered a separate category. Opiates can legally be prescribed as pain medications. Often they're combined with other substances and produce things like Vicodin or Zydone or Lortab, things that you are given when you have surgery, joint replacement, C-section, even things like getting your wisdom teeth pulled out. These sorts of opiates are prescribed and they're generally combined with ibuprofen, things that are, reduce swelling in the body in order to help manage pain. Unfortunately, what can happen is that these an individual can become addicted to these pain medications. Slide 29. An illegal opiate that a lot of us know or have heard about is heroin. It is estimated that about 500,000 individuals are addicted to heroin. And the thing about heroin is that they do account for a pretty large percentage of our drug-related hospital admissions. About 60 to 80%, 62 to 82% of hospital admissions are connected to heroin. At one time, heroin was illegal. Early in the 1900s, people would take it to relieve coughing or pain or give it to their children to get them to sleep. But then it became very evident that people were becoming addicted to it. In terms of using opiates for pain medications, it's estimated that there's about 6.8 million pain med users for non-medical purposes. In other words, maybe the original prescription had been intended for pain, but ultimately what resulted was addiction, and now the individual is taking them and there's no pain indication for the medication. OxyContin prescriptions, they've jumped over 1,800% from 1996 to 2000. Hydrocodone has gone from 4.5 to 5.7 million users. Oxycodone has increased 43%, and these rates of pain meds, these rates of abuse of pain meds have been pretty stable for the past 15 years, 10 to 15 years, since about 2002. So in other words, rapid and heavy increase in prescription use throughout the 90s, and now an increased awareness that these meds can be abused, but no real reduction in prescribing them. Slide 30. So how does an individual become addicted to an opiate? Well, part of the lure of the opiate is that it does produce euphoria, drowsiness, a lack of coordination. So this sort of loss of inhibition and this increased self-confidence has addictive psychological properties to it. Unfortunately, it has a pretty severe letdown after about 4 to 6 hours. So often what can happen with these is that the individual takes the opiate, they feel good or euphoric or even just tired, and they fall asleep. And then once the effect wears off, they feel terrible. They have a pounding headache, they physically don't feel well, and they need to take the medication again. That's what makes them so addictive. When we look at things like heroin, OxyContin, often individuals describe a rush, which is this sort of intense feeling of warmness and ecstasy. What these medications do, what these opiates do, is they stimulate the receptors of the body's opioid system. And tolerance has a tendency to develop pretty quickly, and then withdrawal occurs. So just as I explained before, once that letdown happens, the tendency is to want to remedicate, is to want to take the opiate again. And as time goes on, that tolerance builds and builds, and the withdrawal becomes more and more severe. When we're talking about withdrawal from opiates, we're really talking about a lot of muscle soreness, almost you feel like the flu. Like you have the flu, a lot of twitching, tearfulness, yawning. It can include things like cramps, chills, sweating, increased heart rate, blood pressure, insomnia, and even vomiting. When an individual goes through withdrawal from opiates, it lasts about 72 hours, usually 3 days. Withdrawal from opiates almost always should be done within a hospital setting or a clinical setting. Slide 31. When we look at the impact of opiate abuse in a 29-year longitudinal study that followed about 500 heroin addicts, we found that nearly a third, 28%, were dead by the age of 40. Half by suicide, homicide, or accident. About a third of those who had passed away were by overdose. One of the things that we talk about, developmentalists talk about when it comes to addiction, is that we often don't see hard drug addicts live to old age, and the reason is because most of them die. Most of them die by the time they're 40. Many users do resort to illegal activities to obtain drugs, to obtain money for drugs, or to obtain the drugs themselves, prostitution or dealing drugs. We also see a lot of exposure to infectious diseases via sharing needles, things like HIV. There is research that supports that giving out free needles does reduce infectious diseases, does reduce the spread of infectious diseases associated with IV drug use. Slide 32. So here we are. We're looking at the ER visits for hydrocodone and oxycodone in terms of overdoses. This is data from visits done to the emergency room. And as you can see, in 2009, 2010, 2011, we see this very sharp spike. Over 140,000 ER visits for oxycodone. Slide 33. We're now going to move on to looking at amphetamines. Taking amphetamines increases alertness and motor activity, seems to reduce fatigue. When I'm talking about amphetamines, I'm talking about synthetic stimulants, things like benzodrine, dexedrine. It triggers release and blocks the reuptake of norepinephrine and dopamine. Produces very high levels of energy, a lot of sleeplessness. Reduces appetite, increases heart rate, constricts your blood vessels and skin and mucous membranes. High doses can lead to things like nervousness, agitation, irritability, even things like paranoia and violence. We see tolerance develop pretty quickly. It can develop only after about 6 days of use. After about a week of use, we see individuals start to develop a tolerance. And so they need to take more amphetamine in order to get the same level of reaction. A lot of us have heard about methamphetamines, meth use, also known as crystal meth. Missouri has a high level of abuse towards meth. Ironically, so does Hawaii. It's basically an amphetamine derivative, and it can be taken orally, intravenously, or intranasally through snorting. Chronic use of meth does damage the brain. It has long-term impacts on dopamine and serotonin system. We do see a reduction in hippocampus volume. In other words, the hippocampus shrinks. And this image here shows what meth use can do to the hippocampus in terms of its volume. Slide 35. Another stimulant is cocaine. A derivative of cocaine would be crack, which is a form of cocaine that quickly became popular in the 1980s. It's a crystal that is heated, melted, and smoked, generally cheaper than cocaine. There's alkaloid obtained from coca leaves, which reduces pain and produces euphoria. Cocaine blocks reuptake of dopamine in the mesolimbic areas of the brain. When an individual overdoses on cocaine, they get chills, nausea, insomnia, paranoia, possibly hallucinations. It could lead to a heart attack and even death. Not all users develop tolerance for cocaine. Some do become more sensitive, and that may increase the risk of an overdose, but generally we don't see a lot of tolerance development with cocaine. We have seen a general decline of cocaine use, particularly from 2002 to 2009. It is under 2% generally within the population. Crack use also declining. A couple things to point out, though, when it comes to stimulants. We have seen an increase in use, particularly stimulants, though it's a slight increase, with high school students using stimulants, believing that those stimulants will help them study better or perform better or be more active. And in fact, that is just simply not the case. Stimulants, it may feel as if you are more focused, but in fact, for many individuals, it's actually more agitating, and they actually have a harder time focusing. Slide 36. All right, I'm going to finish up our discussion on illegal or illicit drugs with hallucinogens, ecstasy, and PCP. A typical hallucinogen is LSD. The effects include colorful visual hallucinations, a psychedelic trip, the sort of expansion of the consciousness. Only about 1 to 2% are regular users. African Americans are actually less likely to use than other people. It may create flashbacks in that individuals. Flashbacks it's a hallucination that persists, and it can recur during stress, where you're seeing something that isn't actually there, though it feels as if it is real. Other hallucinogens include mescaline, psilocybin, also known as mushrooms, ecstasy. I want to talk a little bit about ecstasy. Ecstasy has a tendency to make individuals to enhance their moods and increase feelings of intimacy. It makes a person feel happy, makes them feel loose. It also has a tendency to keep them up. And what happens is that they will stay up, and after a certain point, they crash. What we find is it acts on the brain serotonin levels. And as time goes on, it sets the individual up for major depressive disorder, for MDD. Use of ecstasy is harmful for the brain and can set an individual up, particularly if that person, if depression runs in that person's family, to develop depression. In terms of its use, it seemed to peak out in 2001, and then it declined. It may be rising again. PCP, also known as angel dust, is an animal tranquilizer. It can cause severe paranoia and even violence.